going to continue on and talking about depression a little bit more today, and especially medical treatments for depression, and talk about treating refractory depression or difficult to treat depression, as well as treating bipolar depression, or the depressed phase of bipolar depression. And in some ways these two might even overlap, because sometimes refractory depression or difficult to treat depression might be bipolar depression, which is very difficult to treat. Not all refractory depression or difficult to treat depression is bipolar disorder, but some of it is. We talked before about the different types of antidepressants, the MAO inhibitors, the SSRI antidepressants, the tricyclics, the SNRIs, those that block both serotonin and norepinephrine reuptake, and then the dopamine reuptake blocker, Wellbutrin. And just a few comments more about those in terms of how they work. I mean, kind of a crude way of looking at the reuptake blockers is that once the neurochemicals are released, whether it's serotonin or norepinephrine or dopamine, there's a mechanism to take those neurotransmitters back up and recycle them, repackage them into vesicles for them to be released again. And there's billions of neuron cells in the brain, and there's a communication system between electrical conduction and chemical conduction. And there's a synapse between neurons in which chemicals are released and traverse the synapse and then connect on receptors. And so once neurotransmitters are released, in this case whether it's serotonin, norepinephrine, or dopamine, there's a system in which they are taken and repackaged and reused. Well, we think in depressed states that those neurotransmitters are depleted for whatever reason, and by blocking the reuptake, they stay out there longer in the synapse and work longer. And what I tell people, it's like getting more miles per gallon out of your car or out of your fuel. And so whether it's Prozac or whether it's Effexor or whether it's Wellbutrin, that molecule gets on the reuptake mechanism and blocks the reuptake of the particular neurotransmitter, and so it stays out longer. You get more action out of it, more stimulation, and that in essence is a crude way of looking at how it works. When a single antidepressant isn't working, a second one is tried, sometimes in the same class, sometimes in a different class. Sometimes a different class is combined with one in another class. A full court press would be something like using Wellbutrin with Effexor, in which case you would be on two antidepressants that are blocking the reuptake of serotonin, norepinephrine, and dopamine all at the same time. There are cases with refractory depression when you maybe have tried some other strategies, which we'll get into, that you might even look at combining an MAO inhibitor with another antidepressant, which is risky but can be done. And then you are working in two ways on the neurochemistry. One, you are blocking the reuptake of a neurotransmitter. At the same time, you are interfering with the breakdown of the neurotransmitter by catechol O-methylene transferase, the COMT enzyme, which breaks down monoamines in the synapse. So that is done on occasions in people that have had real refractory depression. More typically, strategies that are pursued are augmenting an antidepressant with lithium, because lithium has antidepressant properties. Adding a atypical neuroleptic that are sometimes used or often used in bipolar disorder. Such a typical one would be Abilify, which is FDA approved for that. Rexulti is another one. There are other ones, but those would be typical ones. And using thyroid hormone with an antidepressant. There are studies that have shown that more so in women than in men, that the use of thyroid hormone may convert partial responders or non-responders to antidepressants into responders. There's two types of thyroid hormone, T4 and T3. T4 and T3 are named such based on how many iodine atoms are on the thyroid molecule. Obviously T4, there are 4 iodine molecules, and T3 there are 3. T4 is the predominant thyroid hormone in our bodies. T3 is a minority acting thyroid hormone, but in some of the studies, T3 is the one that's often used. Goes by the trade name Cytomel. T4 is levothyroxine, and T3 is triiodothyroxine. Some other things that are utilized are stimulants, methylphenidate or Ritalin, or an amphetamine such as Adderall or Vyvanse, or maybe even a narcolepsy medicine like Provigil could be used. Some atypical antidepressants like Lamictal or Lomotrigine, which is also FDA approved for treating bipolar depression. Symbyax, which is a combination of Prozac or fluoxetine and Zyprexa or olanzapine, which is also FDA approved for bipolar depression. And that would kind of be like augmenting an antidepressant with Abilify, since Zyprexa or olanzapine is in the same class as Abilify. And brings up the issue that when we do augment with Abilify and it works, that maybe sometimes the issue is that it is a bipolar type depression. At least may raise that issue. Then there's Latuda, which is FDA approved for bipolar depression. That could be used in augmentation like Abilify as well. Omega-3 fatty acids, which you can get at the health food store in the vitamin section, have some effect on the serotonin system and could be utilized. And even benzodiazepines, if there's a high degree of anxiety with the depression, may also give some relief or augmentation to the antidepressant medicine. Possibly other hormones such as testosterone or estrogen would be considerations as well. But it would take time to work through all these different augmentation strategies, and all of them have to be considered based on people's medical history, their health, and side effect possibilities. And so that's just, again, a brief overview of some possibilities for augmenting. One last thing I'll just mention is light therapy, phototherapy with bright lights, 10,000 lux. Lights are measured in units of brightness, or lux, and they're about 10 or 15 times brighter. 10 or 15 times brighter than house lights, and those can be a factor as well, especially during the winter times of the year, maybe more so in the northern climates than the southern. But I've seen that both up north when I lived there, more so, but also in the south where I live now, that it also occurs in sensitive individuals. So anyway, that's, like I said, a quick overview, and thank you.